Well, I'm Bethany Seale. I'm a nurse anesthetist, and I'm excited to present my qualifying exam on malignant hyperthermia, emergency preparedness, and I'm going to focus it on the ambulatory surgery center setting. I'd like to thank my chair, Dr. Joni Jackson, for all of her support throughout the beginnings of my project. And then, of course, my community member, Steve Harbin, who's also a CRNA and works in my group. There we go. Whenever a patient comes in to have anesthesia, they're going to meet with an anesthesia professional like a nurse anesthetist, and they're going to go over with the patient their past medical history, surgical history, and then their anesthesia history, and if they have any pertinent family anesthesia history. And we do that because we want to go over potential complications and how common they are. But specifically, we want to find out if the patient or any family member has a history of a disease called malignant hyperthermia. So what is malignant hyperthermia and why is it important? It's an uncommon genetic condition affecting several different genes potentially, but most commonly RYR1. And it results in a mutated skeletal sarcoplasmic reticulum. And I've got that highlighted in yellow there. When that mutated sarcoplasmic reticulum is in the presence of certain triggering anesthetics, like the depolarizing paralytic succinylcholine, which we commonly use for intubations, or volatile anesthetics like the gases I have listed there in the top corner that we use to maintain anesthesia, a hypermetabolic reaction ensues. And that causes that mutated sarcoplasmic reticulum to just constantly release intracellular calcium. And clinically, that manifests as sustained muscular contractions. So clinically, we would see severe rigidity where we have a hard time opening the patient's mouth, their limbs are rigid, having a hard time ventilating. Those muscles begin to break down and myoglobin is released, so their urine begins to look like cola. And that hypermetabolic cellular activity leads to increased oxygen consumption, increased CO2 production. So we would see on our end on the ventilator, their end tidal CO2 just continuing to go up, acidosis, tachycardia, tachypnea. And that metabolic rate will eventually produce fever, which can be as high as 108 degrees Fahrenheit. As this continues, cells begin to die because they're depleted of ATP, and so potassium is released. And if an intervention does not occur, the patient will experience multi-organ failure, DIC, cardiac arrhythmias, arrest, and possibly death. And so the key to all of this is what my project is focusing on is preparing providers and facilities to be able to recognize MH and treat it quickly. And the treatment, the big antidote is dantrolene sodium, which I've pictured there, and it works directly on that receptor, stopping the calcium being released. So how common is MH? Approximately 1 in 2,000 patients are MH susceptible, but the exact incidence is unknown. So not all of those patients that are susceptible will actually present with an MH crisis. So between 1 in 10,000 to 250,000 patients have a crisis. Children less than 15 comprise over half of these cases, with male patients being affected disproportionately more than females. There is geographic variability where we can see geographic hotspots. Certain states, there's increased likelihood of an MH crisis. And there is increased susceptibility associated with certain myopathies, such as central core disease, multi-mini core disease, or King-Denborough syndrome. So although uncommon, when MH occurs, prompt recognition and treatment are key to patient outcomes. So experts recommend that emergency preparedness measures must be personalized to the educational and logistical needs of each facility. So a facility like a hospital that has seemingly endless resources and staff are going to have far different emergency preparedness measure needs than a standalone surgery center. All perioperative staff need education, and that education should include not only didactic components like a PowerPoint, but also kinesthetic components like a mock drill or simulation, and cognitive aids, because the brain fog associated with a stressful event that doesn't happen very often can be pretty immense and debilitating. Standardization of supplies across facilities is recommended by the Institute of Medicine, and each facility should review and possibly update their MH transfer policies. So in the ambulatory surgery center setting, Even before COVID, ASCs were very popular. And now since COVID, with hospitals having to stop a lot of elective cases and that being shifted to surgery centers, we're doing more cases and patients than ever before. Surgery centers typically operate on lean business models, so they're able to do more efficiently with less staff and resources, which yields the patient and the center cost savings. As MH is most common in pediatric and young adult patients, they are prime candidates for procedures at a surgery center. And MH is a low frequency, high impact clinical event. So typically those lean business model ideals are very beneficial, but in an emergency, if not adequately prepared for, it can become catastrophic. And the two facilities I have pictured there are where I work and where the residency sites are going to be. So the population I'll be targeting is the perioperative staff at the two partially rural ASCs. Both are owned by the same company, Holston Medical Group, or what we call it as HMG. The staff have a mix of experience levels, and it is very, very busy. Meadowview has 2 operating rooms and 1 endoscopy suite, and Renaissance has 2 ORs with 1 interventional radiology suite. There are currently practice gaps between what experts recommend and what we're doing at these centers. Currently, the MH education at both centers consists of didactic education. So when I was brainstorming ideas for my project, I spoke to the nurse managers and they both verbalized a desire for a mock drill to help them implement and practice what they're learning in their didactic education. There's currently lack of standardization of the carts at both facilities, both in terms of where they're located, what's in them, their organization, what they look like. And there is inadequate standardized transfer protocols and report sheets. Currently, it is just call 911. So my project is significant because without adequate education, MH poses a grave risk to surgical patients. The time between recognition of MH and administration of dantrolene directly correlates with MH M&M. For every 10 minutes that dantrolene isn't administered, MH morbidity goes up substantially. After 50 minutes, MH morbidity is 100%. Standardization is vital. The staff at both centers can sometimes transfer between the facilities depending on staffing and scheduling needs. And the transfer period between the surgery center and outside hospital is associated with increased morbidity and mortality. There's plenty of opportunities for miscommunication, medication errors, because just like we're unfamiliar with having to deal with MH on a regular basis, so are the hospitals and emergency medical services. Legally, a precedence has been set that facilities and providers who do not adequately prepare for MH, and if a patient has a poor outcome, they are financially responsible for those outcomes. And an MH preparedness is an accreditation standard. So it's very important because the self-efficacy, confidence, and knowledge base of all the staff is paramount to successful treatment of an MH patient and their potential outcomes. Everyone may need to be involved. It could be a tech, it could be a charge nurse, all hands on deck. So my PICO question is this: how will the implementation of a dual component MH educational seminar improve the knowledge and self-efficacy of clinical staff at 2 ASCs when measured by pre and post intervention questionnaires over a 6-month period? This is a picture of my PRISMA model. It includes sources from Google Scholar, PubMed, and CINAHL. I had a plethora of resources available, so I was able to divide by theme early on. And I considered not only clinical significance, but also statistical significance. And there was a lack of articles specifically focusing on MH and its effects with staff self-efficacy and knowledge. So I also looked at other high impact, low frequency events like CPR and advanced life support, because they can mirror each other with the importance of staff being prepared. These are my driving articles, which I'm going to go over in more detail when I talk about my themes. The overarching theme of my literature search was the importance of MH emergency preparedness through personalized educational and procedural interventions. So what that means is whoever is creating MH educational interventions needs to work with management and the powers that be at each facility to review what their needs are and look at their specific policies and procedures. update them, change them, personalize them to that facility, and then use those specific policies and procedures when training the staff. The 5 themes included educational interventions. As I mentioned before, it was very important to not only have a didactic component, but also kinesthetic and the use of cognitive aids. Simulation was a hot topic when looking at all the literature for my research. Both high fidelity, meaning in a simulation lab, and low fidelity, meaning in situ or wherever the facility is. Simulation were both found to be effective, but I really appreciated the article by Mullen and Bird because they described the importance of using in situ simulation for these kinds of exercises because it allows staff the opportunity to practice in an authentic environment where it would actually happen. Communication practices were very important. Crisis resource management techniques, closed loop communication, remaining calm, practicing all of that with the simulation. Retrieval of qualitative data was an important aspect, not only through staff having the opportunity to talk after simulation through informal debriefing sessions, but also allowing them the opportunity to give feedback on their questionnaire. So this way, if they identify any latent safety concerns, procedural inefficiencies, things that the educator or management may not be aware of, that we could immediately fix to help the process and improve the net of safety for patients. And then transfer planning, identifying what needs to occur to allow for smooth transfer planning between the facility to the receiving hospital. Several gaps in literature were identified. Most of the research focused either on hospital settings or on an academic setting. There wasn't very much focus specifically on the ASC setting. There needs to be more specific examples of low fidelity simulations, not only to reciprocate those studies, but also to allow facilities to actually use that information when they're preparing for MH. And there needs to be additional research evaluating self-efficacy and knowledge as it relates to MH. There's a lot out there on CPR and we need to have more on MH. My project will utilize mixed methods and serve as a quality improvement initiative. I plan to obtain quantitative data through pre and post questionnaires for self-efficacy using a Likert scale, and then also a typical knowledge-based kind of question with A, B, C, or D answers. Qualitative data will be obtained not only through debriefing sessions, but also through the open comment areas and questionnaires. This is a picture of my logic model. I've gone over resources and inputs, the interventions. I'll go over more with the outputs, but as far as my short-term goals are, completion of annual MH education requirements, so our credentialing requirements are met, 100% participation by perioperative staff with education and MH simulation exercises, and a 70% increase in perioperative staff knowledge and self-efficacy relating to recognition and treatment of an MH crisis. Long-term, I hope to increase that to 90%. And I also hope that with time, we will all feel more comfortable with these mock drills, as it's going to be a new thing for us and there's going to be a learning curve involved. The overall impact will be optimal patient safety and reduced risk of M&M for patients experiencing an MH crisis. And I'll go over sustainability shortly. The 3 steps in my project: step 1, assessment, which I've done, evaluating our current MH educational and procedural needs. Step 2 is implementation. So I plan to provide a pre-intervention questionnaire and then do a formal PowerPoint presentation to both staff at the same time in the lobbies of each center, immediately followed by a mock drill, immediately followed by a questionnaire, and then 6 months later, giving another questionnaire to evaluate knowledge base and self-efficacy. And step 3 will be evaluation, reviewing the data and making necessary changes. Of course, if any pertinent latent safety concerns or procedural inefficiencies are noted, I can deal with those with management as necessary right then. We don't have to wait for formal data evaluation to be completed. My project is sustainable as MH education is already an annual requirement at the centers. I've worked with the group that provides CPR and advanced life support measures to the two facilities, and they have a low fidelity mannequin that I can use free of cost, and they've agreed to let the centers use them for the foreseeable future for these purposes. MH treatment is relatively unchanged over the past few decades, and as long as there's anesthesia professionals available to give MH triggering agents, there's going to be anesthesia professionals available to teach MH education. There's several barriers associated with my project. Cost is a big one at any center, but especially one that is physician-owned. Cost is a big deal. Looking at updating our MH policies, procedures included buying new equipment and resources from the Malignant Hyperthermia Association. Time involved with having all of the staff off at the same time, not only from a cost point, trying to avoid overtime, but also from a scheduling perspective as we're so busy. And then staff buy-in. I want them to be enthusiastic and motivated to get the most out of this and to protect our patients. I have immense support from my community member, Steve Harbin, who is the current MH educator, and also enthusiasm from our Chief Operating Officer, Tammy Andrews, and the nurse managers at both facilities. A SWOT analysis was completed. Strengths include the shared staff between facilities, Tammy Andrews, and that MH education is already a requirement. Weaknesses included minimal staffing in a busy environment, which lends to the lean business model. And there are differences in staff experience and staffing between the facilities. One facility seems to have more staffing available to help out with just routine breaks and care of patients, so that could become an issue. Opportunities, expert organizations recommend the use of in-services and mock drills for MH preparedness. As I mentioned, the low fidelity mannequin. And threats include community outreach, since the transport and transfer portion of my project does rely on cooperation from EMS and local hospitals. That could throw a wrench into things. And then, of course, the ever-present COVID-19 pandemic. This is a picture of my project timeline. We're in November and we're clearly in my qualifying exam. But if approved, I plan to start working on standardizing the carts, creating MH education. I already have a copy of the policies and I'm working on that, working on the PowerPoint, and then begin implementing these things in January, February, when our schedule is typically lower as far as our volume of cases. April, May, June, begin data analysis and then obtain that 6-month questionnaire. I've decided to use the synergy model of nursing education as the theoretical framework for my project, and it borrows from the AACN synergy model for patient care. The AACN original version of this looks at alignment of the patient's needs with nurse competencies. So with the synergy model of nursing education, it replaces the patient with a learner and with the nurse educator. So it tries to match these competencies and needs to create synergy to focus on the learner and achieve the best possible patient and learning outcomes. It also looks not only at the educator and learner needs, but also the system in which the learning is taking place. So this is a great theory for my project, as MH experts recommend tailoring educational outreach to the specific needs of learners, and it incorporates what learners need to know for optimal patient outcomes and the specific practice setting. Time is important with this project, so just focusing on what we need to know will be very important. Changes to the system will yield improved patient safety net. And that's it. That's my questions. And here's my many references and acknowledgements.
Thank you so much, Bethany. We'll open it up to your committee first.
Thank you, Bethany. Excellent presentation. And I don't know if y'all caught the fire symbolism between hyperthermia. I thought that was very clever. I'm going to open it up to Steve Harbin. He has been a champion for Bethany and will continue to be. And I just want to thank you so much, Steve, for your ongoing support.
Yeah, no problem. That was a great presentation, Bethany. The work she's doing there is great. She's helping the facility get all the stuff together, and luckily they're actually trying to help, and usually they don't help as much. So it's working out great for us too.
Good deal. Thanks, Bethany. I appreciate your passion for your topic, even though it is very rarely seen, low occurrence. The morbidity and mortality, like you said, associated with untreated or poorly treated events can really be devastating. So thank you for taking this on.
Bethany, this is Dr. Dupre. I just had a suggestion. Yeah, the dantrolene is very expensive drug, of course. What we did with our drills in the past were to obtain expired dantrolene because it is so hard to draw up, as you know. That was feedback from the staff that they know what to do, but the drills really drove home, how hard it is to draw that up, especially when that cortisol levels are at an all-time high. And but we did get some cooperation from drug companies and from some of our outlying clinics that had MH carts where the dantrolene was expired, and we kept that for training. So just in case that is helpful, I thought I'd mention that.
Thank you for that recommendation. Ours is actually set to expire in December, so that will work out perfectly for us. I've already covered them in Post-it notes, like save them for me. So we're going to plan on doing that because that is an important component. The time involved, usually they recommend having 2 staff available to draw it up because it is so time intensive with trying to draw it up and administer it. So that's definitely going to be a component of the drill.
Yeah, I agree. As a fellow CRNA, I agree. As you know, in the Southeast, nobody's 70 kilos. Everybody's a little heavier. And even, like say somebody is 160, 170 pounds, that's anywhere from 8 to 9 vials of dantrolene that you're going to end up having to give that patient. And, reconstituting in 60 cc's, it takes time. And it's 2 is recommended, but the more hands you have on deck to get that patient that medication, the better outcome you're going to have. And that's a really important, physical thing that your staff can see that they don't appreciate until they're literally in a high fidelity situation. And I just wanted to mirror exactly what she just said. And I think that would be a really powerful tool. I think there are a couple, if I remember correctly, there are a couple websites out there that will give it to you for free if you pay for like an administrative fee, like $10 or $12 to get a vial or 2 if you're short at all.
Thank you.
Are there other comments or additional feedback for Bethany?
Yay.
Bethany completes our presentations for this intensive.